Just said, can you hear me all right? Do you want a microphone?
He's got you set up to record if you stand between.
If I stand here, I can't dance. Then I can't dance. Darn. Okay, so we'll stand here. I don't want to cause trouble. So we'll start with some basic definitions, all right? Because you...
Need to turn these lights down a little so the screen might show up better, or?
It's up to the people. Can you see the screen?
Yes.
Can you hear me okay? Do you want the lights up or down? If you go to sleep, I will try not to wake you. So we're going to be kind of basic about things, and but as we said earlier, if you have questions and you want to talk about it at the time, that's fine. I think all of you have heard me say that questions are okay. All right? That's the basis of good medical care, is that questions are okay. And if you remember that, then it will be okay. Because if you don't know what you're supposed to do, you pick up the phone and ask the question. So the same goes tonight, and we'll kind of talk about some things. And if I'm not addressing those needs that you have about what's going on with you, short of a consultation about your disease, I'm happy to help. But I don't have your charts here in front of me. I don't have your MRIs. And I don't really want to share your history with somebody else. So write your questions down for next time if I see you. So cancer, there are a lot of different definitions. The most basic of it is it's an unregulated growth of cells. And they're abnormal because they have lost the regulation. They're not... You have skin cells that divide every day, and that's in a very regulated fashion. But cancer cells lose that regulation, and they don't grow in an orderly fashion. And so because of that, they grow into normal parts and around normal parts and disrupt normal parts or destroy normal parts. Now that's what cancer is. Now you hear the word tumor all the time. Tumor is not the same as cancer. Tumor literally means swelling. So if I'm hammering and I hammer my thumb instead of the nail and it swells, that's a tumor. So a tumor that the doctor talks about can be benign or malignant. It doesn't have to mean it's cancer. A lot of the times you find in a cancer clinic that people are talking about their tumor, then that is malignant. But you have to know for yourself whether yours is benign or malignant. So far, so good? Okay. So a benign tumor usually can be slow growing, like a wart is a benign tumor. There are benign tumors in the brain that grow very, very, very slow. They commonly have a real distinct border. So it's like a button on the table. I can put a ruler on either side. And they rarely spread. Malignant usually are going to be more rapidly growing, and they are more likely to invade. And some people think of that as having fingers, but it means it kind of presses on. And they're more likely to be life-threatening. However, a benign tumor in the wrong place can be life-threatening or cause death. Okay? So if I have a benign tumor that's been growing in my head, and it grows in a place where the surgeon can't cut it out, then it's going to impinge and push on normal things. One of the things about brain tumors that makes them different is that if I have a cancer growing on my hand, I can cut the hand off. I can make my husband carry it. There's a lot of different things I can do because that hand is not essential for life. Okay? It doesn't limit my life to have a big hand. But if I have something growing in my head, it's growing in a box. So it's growing in a nice hard box that protects me when I fall off my bicycle. The skull bone protects us. But it doesn't help if something's growing because that something doesn't have any place to go. So if you have a brain tumor and it's growing and it's in the normal brain, it pushes on that normal brain, pushes the normal brain up against the wall, which is like hammering your thumb between the wall and the hammer. And what happens when you hurt and injure something like that? It swells. So not only do you have the damage done by the cancer growing in the closed spot and pushing, you have the damage done by the swelling that's caused. So a lot of people get steroids, okay? And particularly first time you come in with a brain mass, the doctors give you steroids. And it may shrink it very dramatically and helps get rid of that swelling. And then after surgery, we continue it for a little while and then get people off of that. But it's meant to help the swelling caused by the pushing and the pressure from the tumor. So benign brain tumors can be dangerous, and people can die of a benign brain tumor if it's in the wrong place. It just usually takes a whole lot longer than if it's a malignant one, which is more likely to grow more quickly. Okay. So what kind of things some of you may have experienced in your families or yourself? Brain tumors can cause change in personality. It can cause you to have problems with your memory. It can cause, when we talk about cranial nerves, they're the nerves that make your face run. So your smile, your eye function. So you can have those nerves impaired, so you droop. So your tongue, you can't swallow, or your tongue goes the wrong way. You can have holes in your visions. I had one young girl that she learned she had a brain tumor when she went for her driver's test, and she was doing the eye test at the driver's license, and whoops, there was a big old hole where she had no vision. She really, because she was young and otherwise healthy and compensated by the other eye work, and hadn't realized there was no vision coming out of that eye because she had a rather large brain tumor in the wrong place. You can have weakness like a stroke. People can come in with presentations like a stroke. You can have a seizure, which is caused by irritability of that brain tissue, and that can cause it. Now, all those are caused by the cancer being in a particular place. Other things that you can have can be caused by that pressure building up, because we talked about it, you got something growing inside of that box and creates pressure, and everything's under pressure. It's a little like stepping on the hose and backing things up. There's pressure builds up in there, and pressure builds up in your head. And those kind of symptoms are nausea and vomiting, most particularly in the morning. Sometimes trouble walking, inability to keep your balance. Sometimes, again, personality changes will occur. Being very, very sleepy, headaches, and then we talked about seizures. Now, one thing, a reminder to people that, there are tons and tons of headaches in the world, and brain cancers are not very common, okay? Didn't start with that, and we could very well start with that. That depends on the statistics you look at. And if you look at the benign ones included, there's less than 100,000, probably around 88,000 people a year get brain cancer, as opposed to, say, breast and lung, where you're talking about hundreds of thousands. Brain cancer is not particularly common. Let's see if I can make that work. Oh, there we are. So we think of brain cancers in two different ways, and you will hear these things talked about, and that's another reason to learn about things in general, and then to learn the specifics of yourself. So secondary brain tumors, are also called metastatic brain tumors, are much more common than primary brain cancers. And that means, the secondary means they came from somewhere else. So I have a lung cancer, I have a mass in my lung, the cells get in the bloodstream and travel up to my brain and set up housekeeping. That's a secondary or metastatic brain cancer. And they are much more common than the primary malignant brain tumors. It's around 25,000. Whereas secondary malignant is 75 to 100,000. And the most common one of those is lung cancer, and the most common cause of that is still smoking. So this is a picture. Can you hear me when I'm here? No. Can you hear me?
Not very well.
Okay, well, better? Okay, so if I can make this picture. This is a picture of a brain metastasis, actually several. And this spot right here, the white, is the cancer. And this darker gray around it is the swelling that it's caused. And you can see it looks like I dropped a nickel there. It's nice, smooth. Okay. And down here is another set of them. There's another dime and a little bitty dot, and these. And again, those are metastatic or secondary. And then the dark around it is the swelling that was caused. The factors that we look at when we're treating them, we look at how many there are, where they're at, is the primary cancer controlled, and how good a shape the person's in. And those help us decide whether we're going to treat and how we're going to treat those kind of tumors. If a patient's otherwise dying of other disseminated disease that I can't control, you may not put them through any kind of surgical treatment or radiation type of treatment. But if they only have one lesion and their cancer is controlled, they may go through the same aggressive surgery radiation type of treatment that someone with a primary brain tumor. So it's all put into that same thing. When we look at primary brain tumors, you have to look at the whole person, what their age is, how their performance status is. And performance status is a word that we use just that describes how healthy someone is and what their general activity level is. And when I started medical school, that was a brand new thing. And you would study lung cancer patients, and you would be studying somebody that came in on a cart and comparing them to somebody who was found to have their lung cancer when they broke their arm climbing in a tree. So those two people aren't going to do as well, are they? The person who comes in on a cart, he's going to be sicker and not able to tolerate treatment, and the person who fell out of the tree, that's a pretty healthy person who can tolerate it. And at that time we learned you can't compare apples and oranges when you're talking about treatment. This man is not going to do as well as the one who's walking. And so the same thing goes into looking at people with a primary brain tumor. In anybody with cancer, whether you have lung, breast, colon, we have to look at their performance status to know what kind of treatment. Now, what you guys are here mainly about, I think, although we did last time have some secondary cancers come talk to us, is the primary. And as I said, it's a pretty small number. There's 1.4% of all cancers are primary brain cancers. So it's not very common. The majority are gliomas. Okay, glioma is kind of a generic term, like I might call it a cola. And then under cola, there's Pepsi and Coca-Cola and RC Cola. All right. Whole bunch of different kinds on this slide. And the most common thing that we see is, if I can make this thing work, the glioblastoma. This is one of those glioma cells. And the reason it's all up front here is because they're much more common in the front part of your brain than they are in the back part of your brain. They're much more common in older patients, generally over the age of 55 into the 60s, whereas the patients who have pilocytic astrocytoma, which tends to be towards the back and is a very slow-growing cancer, is more often in kids. So each type of glioma or brain cancer has a particular kind of classic way that they may present. So patients with glioblastoma are usually in an older patient. They may present with a seizure. They can look like a stroke. They can look like a personality change. Meningioma is a benign tumor. In general, most of the time, 95% it's benign. More common in women, increases with age. Some of those we never treat. Some of these we find by accident because somebody falls down the stairs and they're followed for years and never have to be treated. So each of the different kinds of glioma has a different natural history and different way of behaving. So far, so good? Okay. And again, when you look at the patient, you look at a number of different things that help you decide what their prognosis is and how well they're going to tolerate a treatment. Age. Unfortunately, the older that we are, the less likely we are to do better with treatment. The grade of the tumor. Okay, so what does grade mean? Most of the time when people talk about cancer, they say, oh, I have stage 4 cancer. I have stage 1 cancer. I have stage 3 cancer. Brain cancer, we don't stage. Now, what is staging? Staging tells me where the cancer is. So the cancer, stage 1 breast cancer, started in my breast. It's in my breast only. I don't have it in the lymph nodes, the liver, or any other place. Stage 1 lung cancer, I have a spot on my lung. I don't have it in my lymph nodes. I don't have it in my liver. I don't have it in my bones. So we stage it by where is it? Is it in the organ it started? Is it in the lymph nodes that drain that? Is it in another organ? And every kind of cancer has a different staging system. But brain cancer doesn't stage because brain cancer rarely goes anywhere else. It's extraordinarily rare for brain cancer to go anywhere else. The brain doesn't have lymph nodes, so we don't need to have the lymph nodes, whether it goes to the lymph nodes or not. So we do grade them, and grading has to do with how they look under the microscope. So if it's a cancer, if it's a cell that looks like it belongs in the brain, and then you look at how much it looks like the normal brain versus how wild it looks. So a grade 1 is going to look so much like normal brain. Yeah, it's going to look so much like normal brain that sometimes you won't recognize it as cancer. And if you don't have a good neuropathologist, they may not recognize it. The grade 2 looks a little different, a little angrier. 3 and 4 are definite cancers. Most any pathologists are going to recognize it. And I don't know what I'm doing with that light. I'm sorry. So the grading is going to help me know what the prognosis is. So in a grade 1 tumor, that person, like a grade 1 meningioma, can live for years and years and years and years with me doing nothing because it grows very, very slowly, whereas a grade 4 glioma is a glioblastoma, and the glioblastoma grows very quickly, can grow in 6 weeks to more than double its size, and that's a different thing. Again, your performance status, if you are otherwise healthy and you come in and you have good lungs and good liver and ambulatory, can walk around, then I got a better chance of giving you successful treatment. And in most brain tumors, not all, because some are different, the amount that I can cut out is important. Okay, so if I have a tumor that's located in a really important part of my brain and I can't cut any of it out, I'm not going to do as well as if I have a brain tumor in a part of the brain which I don't really need. It's kind of hard for me to believe still to this day there's parts of my brain I don't have to have, but there are, and there are parts that you can cut out and people live and never know by their functioning that there's anything missing. So all of those go into helping the doctor predict what the prognosis is. So we kind of talked about this in the glioma and the grading, and the low grades are much less common than the higher grades, and more than half of the primary brain tumors are going to be in that glioblastoma or high grade part. Because it's the most common, and we're going to talk about others, guys, don't get discouraged here, but because it's most common, we're going to cover it first, and that glioblastoma multiforme is an old-fashioned term that all of us doctors still fall back on. We all still call it glioblastoma. We all call it GBM. The World Health Organization, who's the pathologists who decide what we should say, would say I should call it a grade 4 malignant glioma or grade 4 malignant astrocytoma. This is the most malignant, invasive, and difficult tumor there is to treat. And some people think even among all cancers, it's the most difficult, not just among brain tumors. We already talked about it's in older people. It can double very, very quickly. And the average survival or median, which means that half the people have died by that date and half live on, is somewhere around 12 to 14 months. With newer treatments, you can have it longer than that. Let's see, what else I want to say. So that could be GBM, grade 4, glioblastoma. You'll hear all those terms used interchangeably. A grade 3, that has to do with, again, an astrocytoma, but this one isn't as fast growing as the glioblastoma. It's called a grade 3, and it's less aggressive. And what we've learned, again, when I was a med student, we lumped them all together, the 3s and the 4. And what we learned is later with time is that grade 3s, their median survival is around 2 to 5 years or 3 to 4 years. So they live a whole lot better, and their natural history is a lot better than those people who have a glioblastoma. So we've learned over time that you need to pull them out when you're doing clinical trials. You pull that out when you're doing a prognosis talk with a patient. And the person who has a grade 3 tumor is going to do better than the person who has a grade 4 tumor, as a general rule. Both of these tumors, and in fact, all the gliomas except the grade 1 have another thing that's difficult and different with brain than other cancers. Majority of other cancers, let's talk about breast or lung, there's a lump, and my surgeon can go in and get me what I call a margin. So they cut around it, and they can say, I have a centimeter around it. You have normal tissue all the way around it. With brain tumors, the analogy I use is like sand. So if my grandchild wants me to see something that she got out of the sandbox, but she knows I don't like sand in the house, right? So she drags it in and she puts the pile of sand down, thinking that it's all confined to that place, right? But you and I know that it isn't, right? There's a big pile of sand granules, but there's also little granules around it that have escaped. And so when you think of gliomas and brain tumors, the other part that's different is we don't truly get a margin around it. The surgeon can say, oh, I think I cut it all out. But there's some studies that have shown that if you were to go back in even 10 days later after it's all cut out and look within an inch or so of that hole where it was cut out, you would find cancer cells. That these are just like the sand granules, and it's what the big word we use is infiltrative. One of my neurosurgeon friends, he likes to call it crabgrass. I don't like that because I can pull that crabgrass, you know. I got that tail on that crabgrass, and there really isn't a line that attaches it. It's more of a separate drop of a cell that's mixed in among the good cells. So it's very difficult to cut it all out, and it's why we usually give some other kind of treatment, radiation or chemotherapy, or both, to people that have those. Now this is another MRI, and I think pictures help people. This is the skull bone, okay? And anytime you look at an MRI of the head, you're looking at it, what you might perceive as backwards. This is the right side, okay? And this is the left side. So we've sliced you and cut off your legs and arms and are looking up at you. And what you see, this person was a little bit confused, and so they were moving, and these lines across here are the artifact of someone moving. This big area that isn't a nice dime shape, doesn't have nice edges to it, does it? It's more like I've spilled some milk, or I've got a bad pen that's kind of diffused out in the paper. This is the malignancy. And when you look at the higher grade malignancies, they are usually bright and white because they have broken the blood-brain barrier. So treatments for brain tumors, the first one we usually use is glucocorticosteroids. What is that? It's steroids. Okay, Decadron, prednisone, cortisone, all of those things are used to control edema. Now we have to be careful. And I always tell my residents, you know, don't give the steroids unless the patient's in trouble. The patient's got a lot of swelling, is going to die from it. Don't do it, because there are some malignancies, in particular a kind of even more rare malignancy called a primary lymphoma of the brain, that when I give steroids to, it actually kills lymphocytes and kills lymphoma cells and can make them dissolve for a temporary period of time, and makes it difficult for me to then make a diagnosis that that's what it is. So sometimes you don't get them right off, and I prefer actually the ER doc not just shove the steroids in people the minute they see that. Second treatment is surgery, and I need that surgeon. I need that surgeon to tell me what it is, okay? So I need a biopsy at a minimum, and a very small percentage of people actually are able to have the tumor completely resected. Some of it has to do with where the tumor is located. Most of it has to do with where the tumor is located, and so they'll cut out what they can. And the majority of patients do have something that's left. And here's a picture of that same patient you saw earlier, and we've got the white line around it is the bone. This side is the right side. This side is the left side, and this is the hole the surgeon has left. So it's black. And the swelling is better, and they're not moving all around because they're not as confused. The next treatment we use a lot for gliomas is radiation therapy. And we can use, as a rule, we're going to use what's called external beam radiation therapy. And what that is radiation to the area where the tumor was removed and a couple of inches around it for those little sand granules, okay? We don't do whole brain anymore because we don't help people live any longer and we increase the side effects. But we don't do stereotactic or SRS. And a lot of people hear about SRS, they hear about gamma knife, they hear about all those new cyber knife. And what those are very high doses of radiation given to very small areas, which isn't going to work if you got those sand granules out there. So we know we don't use those stereotactic techniques for gliomas. They haven't been shown to be helpful because we got those sand granules. We got to use a little bit bigger picture to look at it. And then we frequently use, in both those high-grade gliomas, chemotherapy. And in the past we used BCNU and CCNU, but now the drug of choice is a drug called temozolomide. And that is an oral agent that can be used to treat this and has helped people live longer. Now, we talked a little bit earlier about meningioma. We're just going to cover it real briefly. More often in women, more often in the 6th and 7th decade. The majority of them are benign. They can sit there like a rock for decades and never change. They can be a small percentage that are atypical and they don't behave as well. A meningioma in a man doesn't behave as well. A meningioma in a young man doesn't behave as well. So all of those things are taken into effect, and when I decide, does this need to be cut out or not? Number one treatment for meningioma is cutting it out. There's a tiny percentage of people who have actually malignant meningioma, which means it truly is growing pretty quickly, and they tend to not do very well. And this is your meningioma. A meningioma is a meningioma because it grows from the meningeal cells that are the lining cells of your brain. So you've got meningitis is inflammation of those cells, of the meninges. And if you look right here, on the edge of everybody's brain is this nice white line, and that's the meninges. And those cells belong there. And then there's another line of them that's on the other side. Well, this little tumor that sits right here, this is a meningioma. And this is benign. So treatment, observation if they're not symptomatic, if they're older, if they have all those things that tell me this is not likely to be bad. And that person initially is going to get an MRI fairly frequently because I don't know how well it's going to behave or not. By its appearance, I know it's a meningioma. So these are not people that have to go in and have a biopsy. If I decide they have to be operated on by its location, by the fact they're young and male, something else that makes me nervous, then we go in with surgery. If we can't cut it out and they're having symptoms or we know it's going to come back, we're going to give radiation. Or in this situation, you may use that radiosurgery, that stereotactic cyber knife type surgery, because it's very focal. It doesn't have the sand granules. It's just right there. And occasionally people will receive some hormone treatment because these are often in women. And one of the doctors here at KU actually showed that there are estrogen receptors seen on these kind of tumors. So some of them will respond to the same treatment we get for breast cancer. And then sometimes they get chemotherapy. This is also one that was real big. Oh, I'm wrong. This tumor is not a glioma and not a meningioma. This is a central nervous system lymphoma. Now, they're even less common than gliomas, but they're a variant of lymphoma that occurs in the rest of your body. And lymphoma that occurs in the rest of your body is a malignancy that began in a lymphocyte, and lymphocytes are part of the immune system. Brain isn't thought of as a place that has a lot of lymphocytes, but we know that they do get, the brain can have lymphocytes, and that can turn into lymphoma. They can be just like the other, they can be primary, like other primary brain tumors, and start in the brain and have lymphoma nowhere else. Or you can have lymphoma in the brain because you had lymphoma in the rest of the body and it's really out of control and it's spread to the brain. So when a person is diagnosed with something we think is a primary lymphoma of the brain, we always do CAT scans of everything else to make sure we don't have it somewhere else and make sure that it's confined to the brain. The major risk factor for getting a CNS lymphoma is having an abnormal immune system. Not everybody that has CNS lymphoma has something wrong with their immune system, but again, it's something we screen everybody for. We see more CNS lymphomas in people who've had heart transplants, people who've had pancreas transplants, other people, they've had some kind of immune suppression. But we also see them in people, we have no idea why they got them. That's true of primary brain tumor in general. We don't know why people get them. There's a teeny tiny percentage of people who have brain tumors that ran in families because they have some kind of genetic problem. But it's a teeny tiny part of the whole picture of primary brain tumors. In central nervous system lymphoma, I don't try to cut it out because I have really good chemotherapy for it. And the chemotherapy has to be special because of the blood-brain barrier that we talked about earlier. The brain has this barrier that protects us from bad drugs and poisons and things and keeps those things from crossing over. We have to have this chemo get across. And majority of chemotherapy doesn't cross the blood-brain barrier, but the chemotherapy we give for CNS lymphoma does. So we often give high doses of a drug called methotrexate, or we give the temozolomide just like we give primary gliomas because it crosses the blood-brain barrier. Now, in gliomas, we talked about that we do surgery and then we do radiation and we do chemo with it. What we've learned about lymphoma is that if we add radiation to a patient who's over the age of 60, we really increase the side effects. We increase the fact that they'll have more trouble thinking and may even develop dementia. And we haven't really seen that in the glioma population, but we do see it in the central nervous system lymphomas. So we postpone it as much as possible, and only the young patients with central nervous system lymphoma get radiation. And the chemotherapy can be very effective. Pituitary tumors, most of the time I have somebody with a pituitary tumor here. I don't see anybody tonight. These, a majority, they start in the pituitary. They're very common. The majority are benign. They may produce hormones, and that may be how the patient comes to you because they're growing again, so that their tumor is making growth hormone like when they were kids. There's a lot of different hormones that can produce. They may present with trouble with their vision because they are right central in the brain and can affect the optic or eye parts of the brain. We usually treat them with surgery. Sometimes if we can't, we'll use radiation. And occasionally we'll do medical therapy to try to turn off the hormones. So that's just kind of a run through it. I think we've covered 30 minutes, I hope. I haven't done more than my share. No, I didn't. I did 30 minutes, just like asked. So those are just little dabs about it, and hopefully some of the principles you got. But I'm open to questions. We got our 30 minutes of questions, or you can talk about your experiences or whatever what you want to do. Yes, ma'am. Yes. Affect them. Yes, it can. Well, that's the theory, is that we don't, yes, that you can affect. And in fact, actually, there's some information that hormones, in particular estrogen, can affect glioma growth. And there's a recent publication that young women who have low-grade gliomas that we talked about, not the glioblastomas, that we need to be very cautious if they get pregnant because it can change the growth rate of their tumors. So, and they don't have estrogen receptors. So there's a lot we don't know yet about hormones and brain tumors. Meningiomas, there's some relationship to estrogen because they're much more common in women, and it's much more common in postmenopausal women. They do have the hormone receptors, but the hormone receptor doesn't necessarily translate into it'll get better if I give them tamoxifen. Breast cancer, if you have a hormone receptor on that, 80 to 90% of the cancer is going to shrink when I give you tamoxifen or a hormone treatment. Brain tumors, doesn't work that well. Yeah, we don't like hormone replacement. Yeah. Some people look confused. Did I confuse you? No? Okay.
No, I think it's just frustrating.
Yeah, it is frustrating.
I think most people would like to know there's something they can do to prevent, there's a lifestyle, there's.
Yeah, and right now we don't have that. And one of the issues I think, we like lifestyle changes, and I think that you can make associations like with heart disease, that if I exercise and if I'm not overweight and those type of things, but heart disease is common.
Right.
Common. And we're talking in terms of malignant brain tumors, there's less than 30,000 people a year. So it's very hard to make that kind of association with 30,000 people out of the whole United States, and to make that. I agree with you, we'd all love to do that. But I don't. And the only thing I can come back and say is that I tell people is this isn't your fault.
Absolutely.
This isn't because you didn't exercise. This isn't because you ate fried eggs and bacon every morning for breakfast, which my father loved and got his heart disease from. But it is frustrating because it isn't something we know how to change right now.
And you don't think it's anything that was presented to you in your environment?
It's
Orange or fertilizer chemicals?
Yeah, well, the problem with that is, again, if you're talking pesticides, think about how many people get exposed to pesticides. There's data about lymphoma and herbicides, and that came out of Nebraska and Kansas, and our tumor registry here at the University of Kansas proved that farmers have an increased risk of lymphoma because of being exposed to those. But even that, lymphoma isn't particularly common. We don't have a good exposure. We know that if I get radiation as a child for a brain tumor, I'm more likely to get a brain tumor later in that area of radiation. So radiation is a known cause for cancers and can also increase the brain. But there's so few people get radiation as a child, we just can't account for all of it.
And not everybody who does gets lymphoma.
Exactly.
And
that's the other
fallacy.
issue. Right. And that's one of my things. I mean, I think we should be in moderation with sugar, but that's my other issue with everybody talking about sugar is, look at all of us eating cookies at Christmas. I'm sorry, we're not all going to have a malignancy. We'll have other things we die of, and I think you want a healthy diet, but I'm not ready to just bite off that sugar is the evil that's causing all the troubles.
Look at all the relatives that ate sugar, white sugar all those years.
And lived to be 90s, yeah, 80s and 90s.
Example, I'm a first tumor and then my second one was in 2013. Gave an example of the same. Because when I had first tumor, so and then came back.
Mm-hmm.
So this is like my first time going to it. I'm dealing with it.
It's hard.
Because if you're told that the radiation is going to take care of it, and all of a sudden, 10, 15 years down the road, it comes back. It's like, oh. I mean, we gave an
It's real disappointing when you thought you did it.
My mind is trying to wrap around, this is our reality.
Mm-hmm.
And that's why we nailed it, I'm like, if this is what I'm gonna deal with, I need to know as much time.
Yeah.
So, and that's what pushed me to say, okay, start. Yeah, that was, I feel, like, wow.
And I hope these kind of things help you. What I think I also see happen is that today you hear some of it, but you are only going to remember maybe 50% of what I said. Even though this is not very stressful, I hope. You know, the adult literature says we need 3 exposures to things to remember it, and that's when we're not stressed. So that when doctors talk to you about your cancer in the clinic, and they're trying their darndest to teach you, it's why I go back to that questions are okay, because you're not going to remember everything that's said. Even if it's even if it's a classroom, you know, you need 3 exposures. I have all my fellows, you read about it, you listen to the lecture, you read about it. You got to have 3 exposures to all these topics before I test you on it. And so it is something where the awareness, and sometimes all of a sudden it hits you in the face. Or somebody says the right words. Yeah.
I know when we talked about things being our fault, I finally came up with the analogy of the deck of cards. That we all put 2 cards in this life, but 2 of the jokers. It's not that you pull the joker. There's no reason. There's nothing else. You just do
Mhm.
that. So it hurts sometimes. I saw the president
Mhm. They have not experienced it. They have not walked in your shoes. Mm-mm. Mhm. Are you really a twin?
Yes.
I didn't realize that. Okay.
You're a what?
That's when.
A twin. Oh.
He has a sister or one love.
Can I share something?
It's you guys' group.
I had somebody say something to me when I was diagnosed with cancer, and mine was a brain cancer, but they said, oh, why you? And
Why what?
why you? Why not me? You know, and I remember when I was studying biology, one of the things that became very profound for me was what a miracle bodies were. cellular chemistry and cellular multiplication and all of this, but when, the more I studied it, the more of a miracle it was. And I was just in awe of it. And over time, watching things happen and things play out and seeing people, people who were born and so much of their body doesn't function and yet they continue to live. And then watching someone who some little tiny thing happens, a little infarction of their heart, and they drop over dead. And you go, what's the difference? And it's just, I don't know, is it the hand you dealt, the snap of a finger, what is it? I don't know. But it does tell me that we're all miracles. Shit happens. This is what you got, And so, why not me? Why not you? Why not somebody else? But it is what happened. And so, you didn't do anything wrong. It's just what happened. And so, just like if your tooth got broken off, would you ask why you? Okay. Well, I hate to be a city. I might say, well, why me? This is a horrible day for this to happen. Right. But tell me a good day for it to happen. It's never going to be a good day to have a flat
I
tire.
do think it's a pretty normal human response.
Absolutely.
At some point in the time you're told about your illness, whether it be heart disease or whatever it is, it's a very normal response to at some point go, what, why, and what did I do? And try to figure out what I could have done differently.
Right.
And say, I don't want to do this.
Yeah.
Especially when you're trying to go through all the diagnosis, saying, okay, what if I just stay out of this for a while?
Why don't I just go away?
Yeah, well, then you're thinking, then I gotta keep moving forward, so it's gotta be a better day.
Yeah, anything you encounter, you're gonna question. But at some point in time, I think you have to just say to yourself,
Should happen.
shit happens, and it has happened to you, and it sucks. But guess what? You're gonna find her, you're gonna lay down, or you're gonna get up and fight.
It's kind of like people walking along in time, and then there's this door that's in front of them, and they go through the door, and then the door shuts, and then they're in this different space, and they run. A lot of them are trying to figure out, yeah, this is not what I had planned. Did I know that's before? Someone just said it's sense of, okay, this is my space now. How do I move in space before? Again, space, whether it's an accent,
I know in my experience, like even my family, everybody's expecting me to come, even after first surgery, to just be the same. I'm thinking, hell, life just happened. I'm thinking, nobody's, I have to take anesthesia medication now and all this kind of stuff like this. And like, everybody just wants me to
Go to
be.
the doctor, go to
Yes,
MRIs.
I'm thinking,
Yeah, that's your social
hell
life.
no, everything's but they want me to just be the same. I'm thinking I can't go back to be, like you said, in my space. How do I function moving through this now because life just happened? And I even what the therapist said, you were like parallel to your twin, both of you were moving along at the same time, and your life couldn't stop, and his kept moving. So it's like, how do I live in this space and make it, things like that? But I don't, it's weird.
Sometimes I think people want you to keep going because that's their way of coping.
Yeah.
Oh, that's over now, we don't have to worry about it anymore, let's not worry about it anymore, we'll put it on the back shelf. And I don't know particularly for sure, but I know most of the time cancer patients kind of have it always at one here in the shoulder. Even when they're in remission, it's like, when will the next shoe drop, or when will the next x-ray be back, or I have this pain, it must be the cancer. And it is very hard for you just to not have that presence. Now, having said that, you've pursued a lot of different things, as I know most of the people in this room have gone on and lived life with it,
Yes,
and not let it live you.
right.
So, but I hear what you're saying, is that the people are, they just wanna forget. And it's hard to forget.
Like my mom was going on, when I see, I said, somebody want to talk like, no, that's not really, it's all.
Well, might be fine after surgery, if you could say, how are you? Looked fine, I looked fine, but I couldn't say okay. 'Cause I didn't want them to think that I was 100% okay. So I finally came up with that right going forward. And I was kind of stiff, they kind of sit back and go, oh, okay, but I thought I just couldn't say okay for a long time.
Yeah.
And it took me about a year and a half to finally be able to say, and they'd say, how are you? Oh, okay. But
Yeah.
up until then, I was just upright going forward. It's hard, the verbiage is just, like I say, for a while, you want somebody to kind of nurture you a little bit. Sometimes you don't find those people because they don't know how to handle it.
Yeah, and they really don't.
No, we want them to recognize that even though I look just fine, inside I still, I'm not the same. There's little things, so. Or maybe what, but it's still very. I have one man who said, I'm on the right side of the dirt.
There you go.
I'm on the right side of the dirt.
Yeah. I'm looking for the top. Well, that's I found it later. Somebody said you have to find a new reality. That's what it is to you. Our new normal. So
But it is hard to say I'm okay.
hey, just don't feel okay quite yet. And maybe I'm a little melodramatic. I like that too. So.
I had a therapist tell me, she said, if you don't feel okay, it's
It's okay to say that.
you know, just, people, I know for me, you try to make everybody, I'm going through this, but I don't want anybody else to, but I'm the one, so they just get thrown back up and they talk to me, she's like, no, like, it's okay, so, it's okay to say, no, man, it's okay because you can come to yourself. I have to start knowing that.
Hard for us.
Mhm.
How many times do people walk down the hall and they say, how are you? I'm fine. But you may just have learned that your mother died or whatever, and you don't,
Mhm.
it's still saying, oh.
There's a big difference between people you pass in the hallway and your sister.
That's true.
And she better tell me I don't go. I got a cold, okay? She better tell me.
That's true. Yeah, there is a difference, but I do think as our human reaction is to just say, I'm okay.
Yes.